Hello, one and all. Welcome to Pharma Zone. I'm Dr. Sirisha. Today we are going to talk about bisphosphonates. The picture here clearly depicts the basic difference between a normal bone as well as a bone which is suffering from osteoporosis. The basic osteoid is quite weak in the osteoporosis, which is a hallmark pathological feature found mainly in osteoporosis. So, we being a pharmacology student, let us start with a case study. A 65-year-old man is referred to you from his primary care physician for evaluation and management of possible osteoporosis. Patient complained of low back pain. You being the treating physician, you ordered certain x-rays for which x-ray of the spine showed degenerative changes. The patient is a long time smoker and because of which he is suffering from chronic bronchitis. Now he has been treated with oral prednisolone whenever there is an exacerbation. Right now he is suffering from exacerbation and is on 10 milligram per day of prednisolone. Examination showed kyphosis of the thoracic spine with tenderness. So, you being the physician, what do you think? What further workup should be done and what therapy should be initiated? Before going into the topic proper, by the end of this session, a student must be able to identify what is osteoporosis, what is the basic workup for osteoporosis, what are the just an outline of management of osteoporosis with a note on bisphosphonates mechanism of action, uses, adverse effects, and a small comparison between various generations of bisphosphonates. With this, let us go into our topic. Here, the figure shows the basic difference between a healthy bone which has a normal osteoid and a osteoporotic bone where the lamellae are quite thin and there is a significant loss of osteoid. Because of this, osteoporotic bone has increased the risk of fractures. What I mean by that is even a trivial trauma, a very small trauma can cause spontaneous fractures. Sometimes, without any history, there may be a severe backache and a collapse of vertebra. The best method for investigating osteoporosis is dual energy X-ray absorptiometry. This helps in understanding the bone density, which is very important to understand the osteoid. And this DEXA is majorly done in lumbar spine and hip. Now, let us talk about a small, drug therapy of osteoporosis. Basically, the drugs used for management of osteoporosis are divided into three groups. The first group being anti-resorptive agents, which we most commonly use. The second group are anabolic agents. The third group is the agents which have both anti-resorptive action as well as anabolic action. So, the anti-resorptive agents include bisphosphonates, calcium with vitamin D, and raloxifene. The anabolic agents majorly include teriparatide. The dual action containing drugs include strontium. Of all these groups, today we are going to talk more about bisphosphonates. What are these bisphosphonates? Basically, bisphosphonates are synthetic analogues of pyrophosphate, and because of this chemical similarity or a structural similarity, these bisphosphonates they bind to hydroxyapatite which is found in the bone. So, how are these bisphosphonates classified? Basically, based on their potency, they are divided into first generation, second generation, and third generation. The first generation bisphosphonates, the best example is etidronate. The second generation include alendronate, ibandronate, pamidronate. The third generation includes zolendronate and residronate. Before going into the mechanism of action of bisphosphonates, let us first talk about physiology. What do I mean by that is monocyte usually acts as precursor for osteoclast, whereas the stem cells act as precursors for osteoblast. Monocytes on proper stimulus from parathormone and vitamin D gets differentiated into pro-osteoclast. This on further stimuli gets differentiated into osteoclast. Osteoclast is majorly needed for its resorptive action, whereas the stem cells under proper stimulus gets differentiated into pro-osteoblasts. This gets further differentiated into osteoblasts. These osteoblasts are majorly needed for laying out the osteoid. A fine balance between osteoclast and osteoblast action is needed for maintaining a healthy bone. In the same way, the differentiation of pre-osteoclast into osteoclast needs a rank ligand as well as monocyte colony stimulating factor, whereas this differentiation is being inhibited by osteoprotogerin. So, osteoclast formation needs parathormone, vitamin D, rank ligand as well as monocyte colony stimulating factor. This osteoclast on differentiating forms a resorptive pit, gets activated, forms resorptive pit and results in resorption of bone. This formation of resorptive pit action is inhibited by our bisphosphonates. So the basic gross mechanism of action is anti-resorptive. So our bisphosphonates are basically anti-resorptive. So coming to the molecular mechanism, when whatever osteoclasts are being exposed to bisphosphonates, the ruffled border which is present on the resorptive border of the osteoclast will not be formed. What is the role of this ruffled border? Basically, the ruffled border is important for forming the resorptive pit. Whenever the ruffled border for the osteoclast is not formed, the resorptive action of the osteoclast cannot be performed. So, bisphosphonates, by inhibiting the ruffled border formation, inhibits formation of resorptive pit and further reduces bone resorption. So, in a nutshell, whenever a patient is treated on bisphosphonates, due to its chemical similarity, gets concentrated at the bone remodeling sites, gets incorporated into the bone matrix, and then gets imbibed by the osteoclast, inhibits the ruffled border formation, reduces bone resorption. In the same way, after incorporating into the bone matrix, it also slows the formation as well as dissolution of hydroxyapatite crystals. Because of these two actions, bone resorption is reduced. So bisphosphonates are basically anti-resorptive in nature. Now coming to the significant pharmacokinetic features of bisphosphonates. Usually bisphosphonates are given parenterally and some are given orally. Orally given bisphosphonates, they have very low bioavailability and it is just of 1 to 3% of the given dose, and the absorption is interfered by majority of our daily food intake, which all and also includes iron, milk, tea, coffee as well as fruit juices. These all interfere with the absorption. In the same way, bisphosphonates which is present in the plasma are rapidly cleared, and 50% of the bisphosphonates gets deposited in the bone. These bisphosphonates can cross the placenta. It is very significant. So, the drugs which cross the placenta, the fetus get exposed to them, and these bisphosphonates they get deposited in the fetal bone. Because of these, the bisphosphonates are not given in pregnant females as well as lactating mothers. Bisphosphonates are 50% excreted in urine. Now let us have a small comparison between first generation, second generation and third generation bisphosphonates. The first generation bisphosphonates, that is etidronate, is least potent. Second generation on comparison to the first generation is 10 to 100 times more potent, whereas third generation is around 10,000 times more potent when compared to the first generation. First generation bisphosphonate can be given orally as well as parenterally, and they are very rarely used these days because of its less potency as well as severe adverse reactions. Second generation bisphosphonates include pamidronate, which is given intravenously, alendronate, which is given orally, and then ibandronate. This can be given either oral and intravenous. depending upon the requirement and the indication. The third generation includes risidronate and zolidronate. The risidronate is given orally, whereas zolidronate is given intravenously. Now, let us have a small comparison between zolidronate, risidronate, and pamidronate. Zolidronate is a parenteral third generation bisphosphonate, whereas risidronate is a oral third generation bisphosphonate. Now coming to the pamidronate, which is a parenteral second generation bisphosphonates. Zolidronate is majorly used by oncologists to treat hypercalcemia of malignancy, whereas risidronate is not used for that. Pamidronate can be used because of its parenteral route, but the potency is less and is to be given weekly or monthly, whereas zolidronate can be given yearly once. The side effect of osteonecrosis of jaw, which means that the jaw suffers from a severe necrotic reaction, is present with zolidronate. Though the causal relationship is not being established, we usually, as a precaution, do send the patient who is on zolidronate to dental OP regularly to uh, rule out osteonecrosis. This risk of osteonecrosis is never present with risidronate, and a lower risk is present with pamidronate. Esophagitis is highest with risidronate because of its oral route of drug administration, whereas esophagitis is not present, seen with zolidronate and pamidronate. The major advantage of zolidronate is can be given yearly once, whereas risidronate can be given weekly once. Pamidronate, based on the requirement, based on the indication where we are using, can be used either weekly or monthly. The indications of bisphosphonates include Paget's disease of bone, which can occur in both men as well as women, hypercalcemia of malignancy, postmenopausal osteoporosis, osteoporosis in man, glucocorticoid induced osteoporosis, as well as osteolytic bone metastasis. Now coming to the adverse effects. The most important adverse effect is hypocalcemia, because of which almost always bisphosphonates are supplemented with calcium and vitamin D. Because of their route of excretion being renal, they may cause renal impairment. For that reason, we usually do serial monitoring of renal functions. As already mentioned, osteonecrosis of jaw can occur, though the causal relationship is not being established. Atypical femur fractures, muscle pain can occur. With parenteral bisphosphonates, thrombophlebitis of the vein, bone pain, fever, leukopenia, and flu like reaction can occur. With oral bisphosphonates, severe esophagitis can occur. Now, coming to the contraindications. Bisphosphonates are completely contraindicated in hypocalcemia and patients with renal insufficiency, as well as known hypersensitivity to bisphosphonates. Here, I want you all to know a small practice point with respect to oral bisphosphonates. Basically, these bisphosphonates should be swallowed as a whole, should be taken with a full glass of water, and for 30 to 60 minutes before food while standing or sitting upright, and the patient should never lie down at least for 30 minutes after taking bisphosphonates, because they are known to cause severe esophagitis. As a summary, bisphosphonates mainly are anti-resorptive in nature. They have less oral bioavailability. They cross placenta. They are majorly used in hypercalcemia of malignancy, osteoporosis, steroid-induced osteoporosis, osteolytic bone metastasis, and Paget's disease. They oral bisphosphonates are known to cause esophagitis, whereas bisphosphonates can cause thrombophlebitis and flu-like reactions. They are also known to cause hypocalcemia. With this knowledge, let us once again talk about the case study. Here, you can clearly see the patient is already having osteoporosis, but you are ordered only X-rays in the starting, and the patient is already on prednisolone. Here, we can know that osteoporosis either because of age, 65-year-old, or because of smoking, or because of steroid induced. Whatever may be the cause, but the investigations must not stop only with X-rays. We should also ask the patient to undergo DEXA. After all this, when the DEXA shows that the density is being reduced, then we usually start supplementing the patient with calcium and vitamin D first, and then we ask the patient based on his economic status to take some or the other bisphosphonate. We usually prescribe oral bisphosphonates. Thank you for patient listening.